be with us. So in no particular order, I'm going to introduce Professor Joy. Professor Joy is an Ugandan-born pediatric neonatal clinician and perinatal epidemiologist. With 30 years of experience, primarily in sub-Saharan Africa, she has over 380 publications and has been among the top 1% of cited scientists worldwide since 2017. Our main contribution to global health is developing the evidence to measure and address the burden of 2.3 million neonatal deaths, 2 million stillbirths, and 13.4 million preterm births. She collects several 195 countries. Hygiene and tropical, and hopefully you're going to be the next. And mental scientist, especially in Africa. She's one of the few women nominated to both the UK Academy of Medical Sciences and the US National Academy of Medicine. At the Ministry of Health in Tanzania, a medical doctor with a master's degree in health policy and management. He is currently pursuing a PhD in neonatal facility health systems and care outcomes. With over 18 years of experience, Dr. Ndala has had key roles including National Coordinator for Newborn and Child Health and Program Officer for Integrated Management of Childhood Care and Support. He has been instrumental in developing policies and guidelines for technical sessions and championing innovations in newborn and child care. Notably, under his leadership, Tanzania scaled up the neonatal care units from 14 in 2018 to 362 in 2025. And the strategy that was used was them to begin with what you have. Dr. Stanley Slim is a public health specialist with over 13 years of experience in epidemiology and infectious disease prevention. Currently, he serves as Director of Preventive Services and Health Education at Zanzibar's Ministry of Health. He successfully led a mass vaccination campaign that eliminated measles and improved COVID-19 vaccine uptake. Previously, he worked with Doctors with Borders on outbreaks like Ebola and cholera. Dr. Slim holds advanced degrees in public health, epidemiology, and medical science, with research interests in HIV, TB, malaria, and vaccines. Dr. Makoni. Dr. Makoni is a neonatologist and head of neonatal care unit at Muhimbili National Hospital. And just to add, she's also one of my teachers. With over 17 years of clinical experience, she has dedicated her career to improving human health outcomes, she specialized care, mentorship, and health system and health system training. She serves as a national neonatal mentor in Tanzania, where she plays a pivotal role in building capacity and guiding neonatal care across the country. Dr. Koni's research focuses on quality improvements in the care of premature babies, with a particular emphasis on respiratory support in neonatal spaces. Regionally, she is the chair of advocacy and collaboration for the African Neonatal Association and has previously served as Secretary General of the same body. Her leadership, research, and advocacy continue to shape neonatal health policies and practices in Tanzania and across Africa. Dr. Koni is also a recipient of Doctor of the Year Award to just 2024. Dr. Martina, Dr. Martina was born in Italy, and she studied medicine and surgery in Georgia, and she graduated in 2015. She had a master's degree in pediatrics, and from 2021 she works with Doctors with Africa CUAMM. She's head of department of the pediatric department at the Tosa Magaga Referral Regional Hospital in Iringa. Dr. Robert Tigia is a public health professional specializing in sexual and reproductive health and rights. He possesses diverse training and experience in research, healthcare management, health personnel education, and the planning and evaluation of projects and programs. Currently, Robert is a research scientist at the Ifakara Health Institute, where he has served for 17 years. He also holds the position of healthcare quality improvement, country lead with the Next 360 program, and coordinated the results of assessment. Practicing as a general practitioner and training level health workers. Robert's research experience encompasses coordinating studies on malaria and maternal child health, such as clinical trials of malaria and HIV emergency, handheld ultrasound for early complications, essential for pregnant women, a large-scale study of the non-hepatic child. And lastly but not least, Linda Sarai, who's born in the UK and located in London. She has more than 30 years of experience in the pharmaceutical industry, with a particular focus on neonatology. Over a period of 15 years, Linda worked with DS's corporate marketing department, where she was involved in introducing neonatal essential drugs to the nation. She later transitioned to the research and development department, serving as therapeutic area head of neonatology. This role, she and her team managed multiple neonatal drugs resulting in several peer-reviewed publications. In recent years, Linda has focused on establishing a global health department at CUAMM, aimed at introducing high-quality essential neonatal drugs to sub-Saharan Africa through an inclusive business model. The Global Health Initiative also supports capacity building efforts to strengthen local healthcare systems and improve outcomes. As you can see, we have a rich partner. I'm Haika Mariki. I'm a neonatologist and I'm also the Secretary of the Pediatric Association of Tanzania and I'll be operating. I hope your voice is so to get the ball rolling, so in order to attend the SDG Neonatal Survival Target 3.2 and target 3.2 of an neonatal mortality rate.
Privileged to be here at your Tanzania Health Summit. As you can see, I got the dress code. I managed to coordinate with the tab. And it's such an honor to see the progress in Tanzania. So the question is how to go faster. How many of you in the room are runners? Who's a runner? Speed runner, distance runners. So just a couple of weeks ago, Tanzania won a gold medal. One of your first gold medals in athletics. Who knows what the gold medal was for? Gold medal for marathon for a Tanzanian called Simbu, not Simba. And in many ways, sometimes Tanzania doesn't get all the gold medals in athletics. Maybe your neighbors, Kenya, Ethiopia, others, run faster or run longer. But this Tanzanian made it. So why did he make it, and how can we learn from that to help this man, who has the weight of all of Tanzania's newborns and children on his shoulder, to run faster and we run with him? Well, first of all, I would like to present to Tanzania a gold medal for your child's survival. So, it's the Millennium Development Goals for those like me who are old enough to remember them from 2000 to 2015, there were 3 countries in Africa who succeeded. Tanzania, which other countries? Ethiopia and Malawi. Malawi, one of the lowest income countries in Africa. And recently, for maternal mortality, Tanzania has seen a really fantastic reduction. I think you should clap for the progress that has been made. So if we want to run faster, we need to say, how did we already run, and how did other countries run? So in this part of my comments, I want to talk about what to run faster, and later on I will have another question to say, how do we learn from other countries to run faster? So first of all, if you want to run faster, you need 3 things, right? You need to know where you're starting from and where your end line is. Don't go running in the wrong direction. You need to run your time and how fast you need to run. And then you need to know the track and make sure that you're taking the right things and doing the right things in your training. So first of all, the end line. Well, for those who were in the session earlier, Dr. Mundala gave us an excellent summary. So we want to reach a neonatal mortality rate of 12 per 1,000 live births. Now, where is Tanzania at the moment? You want to get to 12. Where are you now? 20? Well, if you believe the last DHS is 24, which was a flat line, if you look at the UN slide projections taking that forward, it's around 20 or 19. Either way, it's high, and the target is low, right? It's about half. How long do you have to get to that target? 5 years. How fast are you going at the moment? Less than 2% per year. So African average is about 1% per year. Tanzania is about 1.5% per year on the last data. So you need to run at least 4 times faster for the next 5 years. So imagine if you're a runner and you're setting out and you need to run 4 times faster. You can't just do the same things, right? So you need to not be distracted, and you need to know what track you're on. So if you look at running 4 times faster, you need to really focus on core things. You can't do lots of extra things. So we know from the evidence there are 2 big things to do. One is emergency obstetric care or obstetric care, and we heard in the previous session with the safer bundle of birth how to do that better on the maternity ward, but it also involves high quality antenatal care. Secondly, you need to do neonatal care. And Tanzania was one of the first countries to do Helping Babies Breathe. I was part of that with Georgina Msemo starting almost 20 years ago. You've done some of the basic things. But the single biggest impact focus for Tanzania for the next 5 years is inpatient neonatal care with quality. That has the highest impact. Absolutely you need to do the maternity care. But I was a neonatologist in the UK in my past life. Even if you have perfect maternity care, you still need neonatal care. We still have preterm babies, the rates are coming down. We can do better with the babies who have interpartum complications, what we used to call asphyxia. But either way, you're going to have babies who need care. And in Tanzania, with 2.5 million babies born every year, 250,000 babies will need some sort of neonatal care. So to run faster, you can't just have 1 or 2 good teaching hospitals. Martha is a wonderful hero to many of us, and what I love about her is she's focusing on mentoring across the country. Because in one teaching hospital, you're not going to solve it for 250,000 babies. It needs every district to have a hospital. So we have a new slogan. We used to have every newborn. Now we have every newborn, everywhere. So for Tanzania to run faster, we need to look to every district. And Tanzania is really leading the way with one of the first published investment cases, which Dr. Gondala was a key lead for, to say, how do we reach each district with a neonatal care unit that is functional? And it's not good enough to have the infrastructure alone. It's not good enough to have the nurses or the devices alone. We really need to have them operational with data that's used, and we'll be hearing about these different parts of the whole system on the panel. But we need to focus on the core package, and that core package is particularly things like kangaroo mother care, keeping the baby warm, avoiding infections, but especially respiratory support. The most common cause of death is for preterm babies, and they need, for example, caffeine to stop them having apneas, but also to have respiratory support like continuous airways, pressure, ventilation, CPAP. And to make that work is really a test of the health system, because you need to be able to do it quickly for the right baby. So it's such a privilege to have the team here, because together what we want to do is to say how to go faster and how to do things differently on a systems approach for every woman, every newborn, everywhere. Thank you.
So 4 times faster means we need to be sprinting now. Dr. Steve, Zambia has been running, and since 2015 there's been a decline in neonatal mortality rate for around 38%. And currently the neonatal mortality rate is 19 per 1,000 live births. So what approaches have you been doing as the ministry to strengthen this neonatal care in collaboration with implementing partners such as
Thank you very much for giving such an opportunity. First of all, I need to convey sincere gratitude for each and every partner that has been involved to allow us to reach those milestones. Tanzania, approximately we have 60,000 delivery per year, right? And that's not a lot, but it's a number, and over which, based on our health system, sometimes can be an operation. Obviously, there are a number of interventions that require a system approach to tackle challenges. Before we used to think taking care of the man will fix everything on the baby, and then we need to prove ourselves somehow it's not right. You know, it's seriously advantage to the healthy mom or the newborn outcome, but there are some challenges that are associated even to a healthy woman. And we were trying to make sure every newborn is given every opportunity to survive and thrive. So we definitely collaborate with most of these partners world around. My sister Liz, S360s, CUAMM, and they're all on board to support government vision, because we believe in any given health system, it's resilient, it's important indicator. So we could do well in every parameter, but if we could lose, we are losing women and children, we are heading toward the wrong direction of the system. So what we have done actually is through quality improvement, and that's very important, but also in terms of capacity building. As Zanzibar, we used to let them graduate from college, they go straight to the theater, and when they are facing challenge, and then only then they realize they'll be tested before you know it, their life is lost. So we engage with chasing, and I propose that we should have AI OBGYN to allow them to learn and have hands-on skill before they get employed to do the work. Lucky enough, we have a skill out that allow our graduates to go and learn enough, not those high frequencies, right, which allow them to really receive the understanding of what really can happen over there. Because while you're in college, you only have modules, but over there, you will get exposed and you'll be supervised until such machine will allow you to tell you, okay, you are now enough or kind of qualified to be allowed in the theater. And that's one aspect that we do. But apart from that, we want to make sure that we improve quality of care in our NICU, right? We work again with every partner, especially CUAMM and Next 316, my sister professor was there. We really try to make what is there that is working and what is there that's not working. That's when we do our assessment in really quantifying the quality on what to do with the gaps, but where we do well. So when we identify that we didn't feel ashamed to share with partner, then we saw people coming for support, right? So what we understand for sure, our milestone that we achieved today is mainly driven by the political commitment that is in Zanzibar, making sure that us as ministry, we want to nurture every parent. That's very important, but most importantly is if anything happens, which normally doesn't happen, but it does happen in Africa, we have every aspect in terms of service point to ensure that baby is given every resource they need to come out and become a better human capital for our generation to come. Doing so, we got involved and we work on our NICU, and we do our best to make sure partners that assess quality in our hospital are on board to give us report, and then we work on those methods. But again, this is not a walk in the park, right? It requires serious dedication to make sure you have the right people in the right place, and if anything, then we find gaps, we even work with private association to come and help us to build those, to strengthen the system, whereas our own people will have opportunity to learn, and hopefully later when they exit indeed Zanzibar and able to take care of those interventions themselves. And I think through that we have seen some changes, and those changes can only be promised if we consistently put the foot on the throttle and continue to remain committed in delivering best health care, but it's a ongoing business. Here we always have challenge, and we try our best to adopt our digital ecosystem, which helps us a lot in delivering best care. But I think most importantly, we have to start with mom, right? If a woman presents herself later that they needed for antenatal care, there are some challenges that we will have missed opportunity. But we use our community health volunteer to actually go in the houses and bring those women to the facility, so the earlier they come to us, we get to know them and we know what's the problem, and we follow them through the treatment pathway. So if there is any problem arise, then we intervene much earlier. But most importantly, one of the most milestone that we actually help us is to able to do the outreach. We have several mobile ultrasound. We do realize there are some specialty where a woman wishes to come to the hospital and probably a couple of dollars, then it's hard to decide whether to take a bus to the hospital or to buy bread and butter for the family. So we have mobile track, especially that goes, and we want to thank the CUAMM for providing us with those mobile ultrasound that have touched thousands of lives. Understanding those women, some of them could have a complication that could render increasing number of newborn mortality. But we managed to tackle that using system approach, but most importantly, we try our best to integrate our service whenever we see a woman, we see everything in it. All those screening are done when we meet a woman in all aspects to ensure they don't have any infectious disease. They are actually the right HB level to allow them to go through. And if none of that seems to tally with our goals, then we intervene rightly. But we could not again do it without the partner at our room. And we really encourage our job as a ministry is to share vision with you, but also to ensure that vision is complementary and each one of you is very resourceful to us. And we want to ensure we put Zanzibar in a pedestal and become one of the model in our writing, how we care for our mama and babies. Thank you very much.
I'd like to appreciate the presence of directors, Dr. Mapani, Director of Reproductive, Maternal and Newborn and Child. So there's a seat in front. Actually, there are 3 seats for Dr. Ona and for the 3 of you. We have 3 seats in front. So CUAMM conducted a facility assessment on neonatal care in Zanzibar, and Dr. Martina, you were part of the team. And if you want to know the details to the key findings, there are leaflets that you found them on the chairs. So what are the key findings of the assessment?
Thank you. Good afternoon to everybody. Have a joining. Thank you to Pratica for the award introduction. And it's a great honor for me to be here at this panel at the 12th Tanzania Summit. I present the results of the survey conducted by Dr. Sudatica CUAMM, the international NGO I work for, and in collaboration with the Zanzibar Ministry of Health, represented by Dr. Sami Smith, and took the occasion to thank him and all the IRC regularly. The survey was funded by the Case Global Health, so sorry, excuse me, I again a few seconds to thank Case Global Health, and especially Dr. Linda Strani for their commitment. But now I go faster, and I go to the findings of the survey. The assessment covered 15 facilities, 11 in British Islands and 4 in the Islands. And the findings, 75% of the facilities assessed in April 2025 had a functioning neonatal unit. All these were covered in the British Islands, 3 over 4 in the Islands. It means that we can say that the target of having 80% of the district with at least one functioning level 2 neonatal unit with respiratory support was there. However, let's remember that, as we said, infrastructures are not enough. This is why it is not very specified, as Professor Long said, that we need functioning neonatal unit with respiratory support. So can the 11 neonatal units evaluated be defined as such? Let's move forward with the assessment, and in the report you can find all the results. Here in the report I will underline just the most important. We divide the report, the assessment in 4 key components: equipment and consumables, human resources, data monitoring, and infection prevention and control activities, IPC. For equipment and consumables, neonatologists, as like neonatologists, we love to remember the 5 most critical products for a neonatal unit that are a phototherapy machine, a digital thermometer, ventilator bags, CPAP machine, and oxygen concentrators. If you open page 30, Latini, in the report, you can see the availability of these items for all the facilities assessed. And if you go in the row of the CPAP machine, you can see that the situation was very heterogeneous. You have the referral hospital, National Hospital in Good Islands, that had a good availability of CPAP machine. In Pemba, in the referral hospital, no machine were there at the moment of the assessment. Then you go down and you have the district hospitals. Again, only 2 hospitals over 9 in that moment and a CPAP machine, the neonatal unit. But I have a good news. Just yesterday I met the MOI of EGTMI and things are already changed from April. About consumables, I will go very fast. Consumables and a good availability. All the most common drugs used in neonatology, antibiotics, phenobarbital for epilepsy, vitamin K and ointment for the prophylaxis were there with a good availability, and in fact that is a good achievement for the Zanzibar Ministry of Health. Just go deeper for the prevention and management of apnea prematurity. 85% of the facilities were using aminophylline. Only one facility at that moment, in the hospital, was using caffeine citrate, and we know that caffeine citrate is the gold standard. Going on the field of human resources, just a data. More than 50% of the neonatal units assessed report a patient's nostration superior to 5/1, with a peak of 20/1. So imagine one nurse with 20 newborns per shift. This is a big problem indeed. But again, also in the field of human resources, a good news. We talked about having baby protocol. All the delivery room, Zanzibar, both in Abuja and Pemba, were using the same protocol for the neonatal resuscitation protocol, and this is a very big achievement. Data. We assessed if the neonatal units are registering data and how. I report to you just an example of the admission register. Okay, in all the world we have an admission register. For the neonatology, for the neonatal unit world, what was recorded very well, 100% in all the neonatal units were data like diagnosis at admission, like referral information, like sex of the newborn. But again, some of the data that are essential to calculate indicators that then will drive clinical decision and policy decision, like body weight at birth, like body weight at discharge, like APGA score was missing in almost one facility over here. Finally, infection prevention and control. We said that it's a core bundle when we set a neonatal unit. We assessed, and 70% of the facility had an hand wash station for the healthcare workers. But again, now focus is on mothers, on caregivers. Only 35% of the facilities had an hand wash station for caregivers. So this is something that we can improve. In conclusion, we can say that Zanzibar neonatal care needs a big progression, but the path is still long, and as we said, we have to run faster. So, from findings to some recommendations. About equipment, of course, it's essential to keep the neonatal unit with the most critical product, and about CPAP, we know that something is already changing. About drugs like caffeine, I leave the floor to Dr. Linda Storani that will update us about the availability of this drug in this country. Human resources, we know, because all the literature reports that investing in human resources can change the outcome of our newborns. And we know that this is a priority of the Ministry of Health, and as like Doctors We and Africa CUAMM, like international stakeholders, we are here to offer our dedication, our professionality to reach together this target. And finally, again, data monitoring and IBC. Everything is in the people. We train the staff of our neonatal unit. We can save more life with a very simple procedure like wash our hands than a lot of other interventions. So again, the point are people and the skills. I think that it's time for our Ministry of Health to focus on human resources, to focus on human capital to run faster. Thank you.
After hearing what Zanzibar has been doing, Dr. Patel, what efforts has the mainland government taken to ensure improved quality of the neonatal health system?
Thank you so much for this opportunity, and also happy to thank the presence of the Director for Reproduction Maternity Mongwan, who is here to just warm this trend of discussion with people. Yes, I think we're talking about the newborn, for which in Tanzania we estimate the impact of 2.5 million, and as I said in the other presentations, from the 13% of these we need admission, and also for this matter, we are talking around 450,000 people who need admissions. They will very much percent of it, I'm sure they will wait. Otherwise, they might die, 7% will very much die within 72 hours if our care is not provided. And so, when we're talking about admissions, means you need a place to admit. This is what I've been finding as an national. But it's not just a unit, you need equipment, you need people, number, but the competencies to provide the services you need to document, having the registers, and also need also the guidelines to guide the providers and that. So those is what you mean in the health systems element of the neighbors, as I mentioned. When we did for Tanzania, when I talk about the mortality, we say 24 per thousand lives died in the Tanzania, 122, which is closely like 131 daily. So by the time we are finishing this meeting, we can take 145 days to find how many people died at the end of the day. But the good thing is the difference. The study said for all these days, 75% of them they are happening within the first 1 week, 50% within 24 hours, and by 80% or more they are prevented. So it's just we need the correct interventions to prevent this. In September 2018, the WHO UNICEF provided a recommendation that we can use 50% or more of these deaths if we essentially newborn care combined with level 2 newborn care. And by talking about level 2 newborn care, we need to provide management for those who have the special histories, the illness, the medical infection, feeding, and the like. So as a country in 2018, we did a simple assessment to see where we were at that time. We came to find out at that time, out of 340 hospitals we had at that time, we had only 18 hospitals that reported they had a neonatal unit. While the recommendation that we need to have a at least in 80% of districts. So when we discussed in the office that building one neonatal unit by that, it's needed like in the district hospitals, needed like $1 million to build in the district hospitals. And for the newborn, for the regional different hospitals, it needed like $2 million according to the standards we had need in addition to that. We wanted a neonatal unit that is going to provide not only for the critical need, but can provide the conglomerate care for premature, but then what for those who are not premature, but they are sick, they are sick in state, but the isolation mode. So we said we have to go in phases. We said we need to go. Phase 1 was to use the starting that we call the start where you are, that you not have. So we said we have the facilities, we have the facilities, and we have the simple facilities here. So we need to design and support the pediatrician, nurses, neonatologists to go all over this facility and assess and encourage the facilities to start or to begin this neonatal units with what they have. They did that, that is what we are quoting, that in a period of 3 to 4 years, Tanzania managed to raise that number from 14 hospitals in 2018 to 362, including that. So what we see now, the admission will increase by starting that, but since we just improvise, and what we published in one of recent publications, we Google Health, you can find it up to your own time, that by the time when we did the assessment in 2018, some facilities have just started in the but they had even maybe 1 billion or so. But when we went there 2 years later, we found all the universities now have the beds, but the admission beds. But what we continue suffering with was the beds were still very few. Because as a national standard is that the district hospitals with an average of 300 deliveries, at least 22 beds are needed. But what we see, we have doubled the beds from 4 beds in facility to 8 beds, but we still need to go further to get more beds. So we after recognizing that each facility, including the sum of the few single point centers that have started in the neonatal care units, we went into step 2, which was expansion of the neonatal care units using whatever resources they available. Thank you, next, who started this to make it in collaboration with the ministry from the 26 beds to 72 beds from that facilities. But as we are talking now, almost 100 neonatal care units have received funding for expansion to have expanded. Starting this year, we are going into phase 3. Phase 3 now is the intensive phase where we are going to build now the modern neonatal care units. And as I'm talking here, the government plus partners have committed fund for building the neonatal care units, 15 neonatal care units from the regional hospitals, of which each neonatal care unit to the regional hospital is going to cost like 4.5 million Tanzania. And that also will be accompanied with the equipment. But again, we're going to build in next 2 years like 42 neonatal care units in the district hospitals, and the high volume centers, like 24 of them, they're going to also receive. Because what you want now is not only to care for the newborn, but also make sure that there is a zero separation. When we talk about zero separation, what not separate the mother, the baby from the mother. What a mother and the baby to stay in the same room with the number of advantage. Number one, we're going to reduce the stress and psychological thing to the mothers, but also the mothers are going to help the staff caring with their babies in the neonatal care unit, but with many other advantages. Some of the communication that was the studies we conducted in Tanzania, Kenya, Uganda, and Kenya, India, and other countries with all those advantages. So by doing this, basically, we are very much optimistic that as we increase the space to admit these newborns, as more people, the sick newborns are going to be admitted within the facilities, the care is going to be provided. So the mortality is going to go down. Because some of the reasons of this newborn being dying is because premature early discharge of which these people they get this done there at home. So in this sense, when we are talking about improving the neonatal health system, basically we are talking about infrastructure, which I have mentioned, but also the issue of the quality of such equipment that is very key for essential newborn care, but for the newborn care. But the issue of the human resources in terms of the number, the government, for example, employed more than 23,000 tests to provide just 2 years. But we have also learned that it's not only the number, but the competencies. Some evidence have showed us from the MPDCR review, where out of 100 maternal deaths, 85% was associated with the competencies of the provider. So we started some different approaches. Some of you know Dr. Madakari, specialist in Dr. Samia, but with how we spoke approach of which we tested with some of the facilities and observed one of the champions within the NICU. We found some of the facilities introduced neonatal death in a period of a quarter, from an average of 50 days in 3 months to 4 days in 3 months. So we're also implementing this kind of approach to make sure that we reduce. But in terms of the data, the registers, I think we observed in that publication what we saw. The 20% of the facilities with the registers represented 80% of admissions in deaths. So that signifies that there was a lot of overreporting. So from that kind of observation, we think also let's apply the registers to the whole of the rest of the government. They printed over 3,000 copies and supplied all over the country. So issue of the financing, we are dealing with different partners to make sure that we increase resources, and of course the guidelines to make sure that they guide our work. Thank you.
They showed 85% of these deaths being caused by the inadequate skills and knowledge of the healthcare providers, and it sounds alarming, and we appreciate the efforts that the government is doing. So, on that point, from a perspective from a tertiary hospital, what are the best strategies to motivate healthcare workers working with neonatal care units?
Thank you, Aika, my student, for a very good question. And I can talk about it as a role of tertiary facilities on addressing the 85% so that we can reduce the gap in neonatal mortality. How can we capacitate? As she has already stated, when you are a medical professional, you are a anarchist. You work with patients. You want your equipment. You want them right. The necessities you want. And you need the knowledge. And that is where the tertiary facilities comes in. We have neonatologists, we have neonatal nurses. So our role is to ensure we build capacity to the healthcare workers that are within the unit. And how do we do that? Within our own facilities, we need to make sure that everybody speaks the same language so that we can address the gap. But also, if we do so well, we need is just one facility. We're not seeing the number of babies that are delivered elsewhere. We need to go down and support them and inspire them to have more ICA coming from neonatology, but to also have champions in their own facilities. Dr. Silva never mentioned their name, to bring that change at their facilities where they're working. And this is the work that the Teachers has been doing. As a neonatologist at the Rio National Hospital, I've been privileged to visit, I think, all the regions in Tanzania, with an exception of Sumbawanga, that is the place that I've not been, Zanzibar, Pemba, twice actually in the region Pemba. And you can see the transformation that is happening when you go for mentorship. And that is, in a matter of like capacity building, you need to empower so that they can have the right skills. They need to own the process. Let them see that this is something that they can bring a change. When you give them the capacity of seeing their own data and support them so that they can make a meaningful programs. What can they do with their own data, which will bring a change? Yeah. And then also what I wanted to say was the issue of availability of equipment. Like she mentioned, Professor Lloyd, if we want to run fast, we need to improve inpatient care in Tanzania. And what does it mean? We need to have level 2. Level 2 is like at least you need to have a CPAP, yeah, for care of premature babies with respiratory disease syndrome. So having a CPAP device by itself and having a person who doesn't know how to CPAP is not going to work. If you have a CPAP and you give it to a wrong patient, it's not going to work. So ensuring that the healthcare carers have knowledge, they have SOP that they can work on, they have cafe, for example, we're talking about at their vicinity, children power. So I think for healthcare workers to reduce that 85%, it's not only about knowledge, but also having the right skills and having the right programs that can address the challenges. But also the one that in tertiary care they need to go down in support. And what I've learned with mentorship, when you go down, we tend to maintain the contact. Today, for example, I see tools which were very inspiring. One, I met a colleague I met in Chato during the mentorship, and I can see they're doing very well. Another was a resident, she got a post in Paris, and she's probably going to pursue neonatology in France. And this is the ceiling that you want to inspire. You know something, but make sure whoever's passing on your hand, they should be able to implement and probably do better than what you do. Thank you.
One of the important blocks in improving the quality of mental care is the affordability of the essential neonatal medicine of care of the small estate, such as caffeine, citrate, and surfactant. So this is still a challenge in most of our settings in the country. What are your views in combating this situation to reduce these inequalities of care?
Good afternoon, everyone, and thank you for the opportunity to be with this very important and question. So, global healthcare department, our mission is very simple because the devil's in the details, so there's people here that have much more meaning. Our mission is to bring the two essential neonatal drugs in WHO, that is caffeine, surfactant, to the sub-Saharan region. Very simple. How in a sustainable, social, business manner. This is not philanthropy. I think everybody knows we need to go over. This is about sustainability. Let me say a few words of why we ended up having this department. Today, our company is celebrating 90 years. It's a family-owned company. We are not going to stop this change. We do what we feel is right, and we feel that every day. We've been in neonatology for the last 40 years. We've spent a lot of money in research. We're proud to say that we were able to develop a very good surfactant, and also to develop and commercialize caffeine in over 100 countries. But this is not enough. We have a foundation, and we started working in sub-Saharan Africa, and we saw inequity, how unfair it was that where you are born determines your possibility of survival. This is not acceptable, but it's not acceptable to me as a person, as a mother. And therefore, in our company, we started to think, what can we do? The first thing we realized, and I love the name of CUAMM, which is Doctors with Africa. So we want to work with the African neonatal community, not for. So partnership. And we're very grateful for CUAMM believing in us, Dr. Slim believing in us, And therefore we started thinking, first of all, caffeine. Caffeine is the most used drug in high-income settings. We said we really need to make this available. And this was an objective we set ourselves. Other people did not believe it. Big donors did not believe in caffeine. They were talking about surfactants and said we need caffeine there. So basically we started on our own. That was 5 years ago. We started working with WHO as well, and we're very proud to say that we received first of all European approval. So this is a European approved formulation. And from there, we were able to get in only 90 days approval of this drug in Ethiopia. And someone said, well, Tanzania always does things better. And we got approval in Tanzania in 90 days. And that was we also had a distributor on board in these units. And I think I am very confident in telling you that the most important thing, and we heard it today, is how a lot of these medicines are out of pocket. We really believe that with our substantially, and I will repeat, substantially lower price, because we have minimized our margins, it will also be affordable to the families. The families will be, as they are doing in Ethiopia, the families are buying caffeine citrate because they can afford to buy it. So we're very proud of that. But furthermore, we do have some operational margin because we are supporting capacity building. Because however good a drug is, if there is not the we've heard, we don't have the right equipment, we don't have the right training, it will not work. So we are supporting CUAMM, we supported the assessment for Zanzibar. We were very proud that from the moment that Dr. Slim and Carlo from CUAMM said we want to run this, 1 year later we delivered to the Ministry of Health of Zanzibar the assessment. Now we know that CUAMM are having discussions with the Ministry of Health of Mainland to run this assessment in mainland. And KISI is there to support us. We want to be a partner in this. And so here I'm here to say that we have made a 20-year commitment to neonatal care in sub-Saharan Africa, because change does not take place over time. This is our commitment. We are measuring our success by the number of patients treated and by sustainable treatment. And this is just the first step, because the other drug that we have and that we plan to also launch in the future is surfactant with the same approach, with a much lower and much more equitable price, by cutting our margins and by investing in capacity building. So we know that the road is very long. We want to be part of that change. We see ourselves, our drugs, as catalysts of change, not solutions. We can't do it alone. You are all doing a great job. We hope to be able to give you a hand and for sustainable change.
So other than accessibility and affordability to this essential neonatal medicine, as a healthcare provider myself, another challenge that I see is data and the use of data. So I'm sure most of us have heard about S360, and it has been implementing its program in Tanzania for 5 years now. Dr. Robert, what approaches have you used to improve the health information system?
Thank you very much. Thank you, the organizers, for giving me this chance to participate in this panel. Professor Joel said that we're in a marathon, and to know, yes, to be able to run and finish and win, you should know where to start. And to know where to start, you really need to assess. So the program, Next 360, the strengthening health information system is one of the gaps which they found that it needs to be, the health system strengthening is one of the priorities which we think that we need to start with to make sure that we'll be able to know where to work and where to improve. So the assessment had to be done. And to do the assessment, you need to have tools, you need to have the indicators which you need to use. But by the time NEST was starting, looking on across all the assessment tools which were available, we found that the information regarding newborn care was little, very little, and few of the tools are the ones which have at least more than one or two variables which can be used to assess the care. So to know how ready are the facilities to provide newborn care, it's very, very important to know what will look at. So for that case, the program had to work with the partners and the governments to design the tools which can be used. And here we came to health facility assessment tools, which is going across all the health system building blocks, and it had around 10 modules, which can be done in the facility to know the readiness, how ready the facility is to be able to provide comprehensive newborn care. And these assessment tools were developed, and the program using them to assess now the facilities. And this assessment was being done to the facilities, the one-day assessment using trained data collectors. And this one used, most of them were medical personnel and the specialists, for example, HMAS and the medical engineers who were involved in collecting this information. After doing this assessment, in fact, was looking on important areas where after the baseline assessment and when we did it later, we saw the improvement. So this tool helped the program to be able to know where to put emphasis, like for example, looking on the family-centered care for newborn or for adults. So this one, in fact, in the baseline assessment, it really scored very low. But after we had implemented the program for 2-3 years, when we did the assessment again, we saw the improvement across the facilities. Another area which was having a very low score was also the use of technologies. We had less technology in the facilities, but after implementation, when we did the assessment again, we saw a big change to the infrastructure, use of technologies, and also issues of skills to health workers. And we realized that without that tool, we wouldn't be able to know exactly where to put the emphasis. So we did this assessment, and later we were looking, because we started with the regional hospitals and tertiary hospitals, it also needed to do in the lower facilities like district hospitals and the health centers. And this one really was, when we had a tool which is comprehensive for higher levels, we was start thinking on how can we do it into the lower levels. So the program was able to have also part of the tool, which facility assessment, which is fit for the lower facilities like districts and health centers. And this we did also with a very good effect. So for assessing the readiness of the facilities is very important, because it helps us to be able to know where to put emphasis, and important is on the planning. For example, the resources we have and to know how should we implement the programs we have, but also to assess how effective our implementation has been. Not only that was in the part of assessment, but while you are running the marathon, you should know the track which you're using. You should not go out of the track, so you should also have enough information of where you are, where you want to go, and whether you know exactly how will you know where you are going. So the program also to strengthen the healthcare information system, we had to look on the variables which we need to provide care. By the time we started, there were different variables, different facilities. For that case, we also partnered with the government and the other partners to come up with the harmonized variables which can be used to plan and assess and come up with looking on the performance, so that we'll be able to know how are we progressing. So we came up with the variables which can be used in the country across all the facilities, for example, and this one, in fact, can help us to harmonize even what we do in the country. Because, for example, you want to assess the mortality, and you can have different mortalities in different facilities or districts. But when we're using a uniform variables which are in line with government priorities, that's what can be able to make sure that even the interventions will be in line with the government priorities. So we were able to work with the government to get the registers, and at the facility level we're able to come up with a dashboard. A dashboard which can help the health workers to assess themselves. They look at the data, they know where they've done well, where they need to improve, and for that case we create the ownership at the facility level to ensure that it's their own data, they own it, and they can use it to assess themselves to move forward or to improve their care. In this, in fact, we also do capacity building. And the capacity building, for example, the assessment we should be using the facility assessment tools. We also trained health providers from the districts, the respective districts and regions, who will remain there to do that whenever they want. So that when we know that we are assuring the sustainability, but also making sure that the health workers are capable of doing it on their own rather than just waiting for programs or projects. So they can do it anytime they want, and this one can bring a very good way of improving care continuously. We will also, when we look, for example, on the data, the neonatal patient data which we're talking about, setting the variables which we made, the neonatal patient data are kept in the facility, and currently we are working to make sure that we can align with the systems which are existing in the facility. So currently they're doing mapping to ensure that at the end we will not be having a problem of collecting the information, because they will be in line with what is being entered into the system of the government. For that case, it might be possible to get this information from DHS2 and the other systems which are using the same indicators like the ones which the government is using. Thank you very much.
With your 30 years experience in maternal and neonatal care across the continent, especially the African continent, what are some of the top learnings that have worked to deliver high quality neonatal care and to see impact? In 2 minutes, top learnings that you can say.
Fantastic. Thank you to you, and also thank you to Dr. Makwani, who has led so much change in Tanzania. So in 2 minutes, my words. So we want to run 4 times faster. We have at least 50,000 newborn deaths in Tanzania every year. So I think we need to make the economic case, not just the moral case. So for every $1 you put into neonatal care, you get at least $9 to $12 back just in deaths averted. So in this room, do we have any economists? I think we're all speaking maybe to the converted. So we also need to involve our families. If you look at HIV and malaria, how they made progress, they had civil society and affected families at the table. We are very bad at making the case we're too nice. Neonatologists are too nice, right, Martha? So we need to do better to say 50,000 newborns dying in Tanzania every year. It's not good enough. Tanzania has so much ability to do better than that if we want to run 4 times faster. Maybe I want to highlight that we need to look at those who are running fastest. So we don't have time to discuss it in detail now. We're just in the process of doing an analysis series looking at fast progressors around the world and what do we know. China is the fastest. China is growing at 8.2% per year consistently for the last 15 years. That's already more than 4 times faster than Tanzania. They put a lot of their own money in. And why do they do that? Because there are very few babies now. It's a problem. So it's also an economic case. They built neonatal units, but they didn't just do the space, they also did the workers, the devices, and the data. The data systems are really powerful, including using AI and detecting what to do. One thing they didn't do was to have families at the time. So for neonatal care, we're looking after not just the mother, but also the baby, which is being designed for the So you can learn from somebody running fast and also see what maybe they did too well. So China is the fastest in the world. Who's going more quickly in the last 5 years? India. India has doubled speed in the last 5 years from what they were doing before. And India, the continent, has almost the same number of births as the whole continent of Africa. It's a huge country. So maybe just to highlight one thing that they've done. Indian government is investing $1 billion a year in neonatal care. Yes, they build, but actually the central government pays the human resources bill. So you move neonatal units from 10 to 300 or something, now you're capacitating them. They move from 60 to 1,064, and the central government still pays the human resources bill. So this is really impressive leadership. So, and then to highlight Africa, so the fastest running in Africa for 20 years is Malawi. And they're doing it like America, a bit, very steadily, but because of that, they are ahead. In the last 10 years, the 2 fastest changing countries are Uganda, where I was born, and Ethiopia. Both of them still have quite high mortality, but they have speeded up in the last few years. And Tanzania, I believe, you will be the fastest in the next 10 years because of the leadership here. So maybe just to highlight important learnings from that. Often we use the word project. I'm part of the Nest 360 Alliance. We've made project a swear word. But actually, if you say project in public, people will stop you. Projects, projectitis, pilotitis will not get us change. We need government-led plans that we commit to. We need to be integrated together. And the government in Tanzania really has ambitious plans. We need to stand with these people and do that in a coordinated way. And then we need this systems approach. We've heard about the right space. There's a national plan floor plan. In fact, if you go to the newborn toolkit, the national floor plan from Tanzania is in the top 10 downloads. You can also download data sets, data tools that Robert talked about facility assessment with all the training and guides, the neonatal inpatient data set. You can download many other things. So Honorati, when he was asked earlier what's the one thing we should do, he said, don't reinvent the wheel. My friends, we have hundreds of training guides. We have good health facility assessment guides. We have a good data set. We have things people can use. Start with those and adapt them. Don't start from scratch. So I want to really say that I have picked to be in Tanzania. I have the privilege of having a sabbatical. I could have gone anywhere in Africa. I was only going to be in Africa. I could have gone to Uganda, where I was born. I could have gone to Malawi, where I have spent many times. I chose to come to Tanzania because I believe that you guys are at a tipping point. And I believe that with leadership that you have here with Dr. Mondala, with Dr. Makwani, technical leadership with people like Martha, and also within Zanzibar as well. With Nest 360, with partners like Yezi and CUAMM and many of you in the room, we can make a choice that Tanzania will be one of the few African countries that will hit this target, and we want to run together, and I believe we can run faster and do this together.
So just to make sure that we are really up to speed, what are the key priorities that the government of Zanzibar is looking into?
then that's we're not a message. I think as we have made, first of all, we need to work yeah, my job as a director, we need to create conducive environment for our partnership to thrive. And how we do it, we need to assess what's on the ground so that whatever it is we do is human-centered. Right? We try our best to not to duplicate effort. So what CUAMM has done in terms of assessment, now whatever comes, we take it from there going forward. Yeah, and we don't have time to waste. You keep emphasizing on the running. Running means if something is working one, we need to see how can we customize it to our context and move forward. We don't have time to keep researching on the same thing when kids are dying, right? So when she presented the opportunity for me, I was thinking that was one of my milestones that would put me in a pinnacle to say that we managed to avert newborn death and the challenge associated to it. And sometimes we have the bureaucracy to keep wondering and questioning why. And each position we've been given, it is because you need to make decisions. And those decisions can make or break life. So we need to allow science to clear the way in every decision that we make. And if it's conducive and I believe it's publicly good, then I don't have to go to my minister to make decisions because I will lose a partner and we will go elsewhere. So what I can say, Zanzibar has no equitable policy. You bring anything to me, it's resolved. Because I know there is no magic bullet to solve the problem that I have. And I just start out them. And if you can come and help me with one level, it means I'm one level off. So my door is open in my office 24 hours. And I love partners because I cannot do without them. And especially that we have ambitious targets and we only got a few years left. I think it's very well with all of us that we need to combine our effort and making sure that Mama is given the right chance, but every newborn is given a chance to survive and thrive so that we can create a better human capital, which is both good for national security, right, but also for our country prosperity, and that's why the whole aspect of sustainability comes. Thank you very much.
The same question. What are our key priorities?
So, thank you so much. Number one, I think we all know that Tanzania has made a big surprise for maternal mortality reduction from 556 to 184 in the span of 5 years. So let's join hands together in the second surprise in 2020 ready. Because you're saying that because we didn't know what is needed. We know we had no services for the newborns. We now know what should be done as a state. Because if you see, even when we were constructing these single-case facilities, which we increased from around 200 to 500 in the 70 or around 600 now, we forgot putting neonatal care units in the single-case facilities. So we just put that in a single facility. So the baby who was successfully within the label had no place to be kept to provide services thereafter. That was one of the big mistakes. But also, I think that mistake also started from women that have been told the guidance, because even the WHO themselves, when they are putting the single functions for maternal care, the level 2 care was not part of it. So they just ended by saying the neonatal stations. Thank God, I think last year they put the early that. So there was a lot of mistake where we all have to accept that we did a mistake. But for now, let's make that we have the appropriate intervention continent, labor and delivery, postnatal, neonatal, and follow-up of discharge. So to do this, I think within short time we will see tremendous changes. Thank you so much.
Before we move to the next session, Dr. Linda, what is KSD Global Health commitment to improve neonatal care in Tanzania? In 1 minute.
In 1 minute, so just to say, with our KSD products, we have treated 6 million babies in 40 years. We want to get that number up to 12 million in the next 10 years, and these will be babies here in sub-Saharan Africa. We want to be part of your journey. We want to give you 2 instruments we can, which are caffeine and surfactant. So then the job is up to you guys. We are going to make this sustainable. This means quality, affordability, access, and long-term commitment. You're here to stay.
We'll now take a few questions. So please state your name and the organization that you come from, and then you say the question and who you're addressing.
Okay, thank you so much. My name is Dr. Manuel James. I'm working at Solidanet. And with the great interest also I think the project that needs to come to the network. So I'm the champion as well. So I have got 2 questions and list of advice. I would like to start with the list of advice and the list of prayer. A few years back, we had a large number of maternal deaths in Tanzania. But now we can study a lot of people that say the government of Tanzania have done a lot as far as maternal death is concerned. So the focus we did put in fighting against maternal deaths in Tanzania has to be the same focus to be put in fighting against neonatal deaths in Tanzania. By so doing, I can assure you we will improve much in terms of neonatal health care. That was the list of advice to the ministry. Now, questions. My first question, much were spoken about capacity building and the incentives to healthcare workers. Currently, nurses, once they are encouraged to go for further education, especially like pediatric medicine, most of them become doctors. They lag behind. The reasons they mentioned, some of the reasons they mentioned, it is because once they go for further education, the scheme of work that will recognize them when they have masters in Tanzania. So how does the Ministry of Health address this? Because if working in the neonatal care unit needs more than professional training, it needs passion. We have people already who wish to go for further training, like masters in pediatric medicine, etc. But they are reluctant because the scheme of work in Tanzania doesn't recognize masters there. How does the Ministry of Health address that? My second question, I heard much from the Ministry of Health regarding the advancement which is done as far as neonatal care is concerned. Much has spoken by Dr. Kundara. They are at the level physically of making sure that small facilities are having also neonatal care units. Does the Ministry of Health not see the importance of revising the definition of abortion in Tanzania? Because currently we now receive newborns being born at 24 gestation age, 25 gestation age, and when they are identified to higher health facilities, they survive. Does the Ministry of Health now not see the importance of revising the definition of abortion so that those kids which are being born below 28 also get a chance of surviving? Thank you so much.
Take 2 more questions.
My name is Wilson from Indian Force. For me, it's not a question, it's just a piece of advice. Because I heard Mr. Kudala saying we are going to have regional hospitals in the district, if I'm not sure. But we have dispensaries which are very far from district level. And there is a lot of delivery there. Even they got the basic healthcare providers have no any skills to help these children, how they will survive life to get there at neonatal units. Thank you.
Thank you. Naitwa Tanzania. I'm from Mwanangu Development, Tanzania, and I'm a activist for child's health and youth. My question is, maybe it will go to all the panelists. We've been discussing about mortality, but in the maternal also, there's a children are born and then they can get a disability, so they are surviving. What are the rates of it? And what are we doing to prevent that? I can give example, even from Tanzania now. We have more children with cerebral palsy born, but we have children born with hydrocephalus and they are getting cerebral palsy during the delivery because they are late to have a baby. So what we can do to reduce this, because these children will be surviving, but they will become the family and the country. But this is a necessary disability we are bringing. So, as a ministry and the panelists, maybe you can help us on this. Thank you.
We'll take the question of the ministry, and when we conclude with the final thoughts, we'll all conclude based on the last question.
Thank you so much. I will respond. And if the director wish to add something on that, he will continue. Number one, there is a focus to maternal should be the same to the newborn, but you should not forget the maternal piece. Because as we mentioned, beta asphyxia is the number one cause of neonatal death. This beta asphyxia starts from the labor, it starts from antenatal care, so we need to make sure that beta sepsis is continuing. So it is true that you are putting now more effort to the newborn care, but you are not forgetting what we have gained to maintain how to sustain that. About the scheme of work, this one is on progress, because it's been presented in many meetings, and for this, I think how to follow up where is it, but I understand within the government this is being taken care of. The definition of abortion, as I said, I'm trying to try something on this, because also that the services. And we know the dispensaries and the Tanzania policy is outpatient policy. So we are not admitting at the dispensaries. But what we are advocating, since they are providing delivery, they need to have what we call the stabilization corner. Because many times we find that before this newborn are being referred, they are not stabilized. So by the end, they will die due to hypothermia or any other complication that they are not stabilized before they get it. So through the mentorship, we train these providers from the center level in the center that from the center level in the center that meeting, at least to know how to stabilize the newborn before you care, but also provide at the end of it. Otherwise, I welcome it. I know you're also part of we can continue.
Dr. Mopani, do you want to add anything?
Good evening. Thank you for raising that question about the legal implications. Say that with the little we have done on neonatal care, we are seeing the change of tides in terms of survival of the prematures. In short, I would use the word abortion, which is illegal, saying that we have seen more babies born for decades, which are categorized in the health as severe prematurity, surviving. And actually, in the department, we asked our MOD team working with our neonatal unit team to collect data so that we can send it to legal team. Because we are also in the process of developing National Health Act so that they can include it in the language of laws, so that when we provide services for these babies, all of us can take in. Because currently, if the baby survives, we say this was very good. But if the baby dies, we say this was an abortus. And you understand that language when you have that situation. When things go bad, you say, but it was an abortus. When things go in your way, you say, this was a very worst somehow. And that is because of the legal implication, because the lot of things we can it is the reality as an abortion. So we are working in that area. And I would say it's a credit for all of us, because for these few facilities that we have put in place, they are providing services. And now, by sharing this legal pieces, means we are something, which I would say will really some progress.
Also add to our national data for neonatal, because currently we do have babies with birth certificates, but they are not counted as live births. Yeah. In the interest of time to conclude, 30 seconds, please. Final words. We'll start from there and then we finish.
Thank you. To conclude, I would like to give out those two things. Firstly, is to focus more on data ownership, to ensure that we build the capacity to the health workers and we build the culture of using data. But this one also need them to be capacitated on interpretation so that they can be able to assess themselves. But also integration of the data or variables to speed up the integration, because the process is in the process. And some of the health hospitals already integrated the variables into their systems. Thanks to the government, where they're putting a very good system of making sure that which facility should have which system, so that with these variables, once they are in the system, they will be harmonized and it will be able to give a very good way of measuring the performances and plans. Thank you very much.
Thank you. I want to conclude underlining as Laura said now, the importance of data-driven decisions. So again, as Dr. Linda said, our ideas, our proposal is to work with the local authorities, with the Ministry of Health, to extend assessment that we do in Zanzibar.
Thank you. There was a question asked about the babies with disabilities. So what has changed good. We are now having a fetal maternal specialist, at least in tertiary facilities, or a fetal ultrasound being done. So in some areas, and this is an area of mentorship that is growing, when the fetus is identified with an abnormality, we start counseling to the parents, and in instances like where I work, we go and we receive the baby. But sometimes we start pre-counseling with the mother, so they sort of anticipate what is going to happen, and we know what type of services they are going to provide. If they are told why there is not really care, that is the most important when it comes to the arrest. The issue of recognition, scheme of service. I'm sitting here today as a neonatologist. 20 years ago when I started my term as a medicine, I was working with the so-called TRA at the moment. My salary was 3 times what the doctor is earning. I got that job, I came to medical school. I've never regretted still then. If you wait for a scheme of services to be changed, you will die retiring, waiting to become a neonatal nurse, a neonatologist, and it will be past, but it will be too late for you. Money is everything, but sometimes it's not everything. Make that call, things will happen. Well trained, we have people who have to quit their job without a salary, for training, and then went back. It is good to be recognized, but you need to know what is your passion. It pays at the end of the day. I'm a living testimony of that. Take home message as a tertiary one, facility, walk the talk. If you want to serve babies, walk the talk. If you are training, walk the talk, and that can make a difference.
Thank you very much for the opportunity, but also the ample time to get exposed to so many specialists around. I think in current times where we really want to strengthen our community and everything will happen at the community level, and we wish we could finish the communication there, so that when what it will happen is only because somehow, somewhere, it was out of the capacity of community hospital, health center, or dispensary. So if we strengthen the primary health care, a lot of staff will just suggest themselves, because we actually no one behind. And if it is not good to have tertiary and super specialist hospital, a lot of people, and when that is visible and something hasn't revived somewhere there or at the grassroots, I emphasize we put our resources there, and then we can able to make early sign, early detection, and then we can able to intervene in the most cost-effective way. But most importantly, today here we have discussed milestones that we achieved. All this could never be possible without political commitment of people who are in front of us. The budget for Zanzibar government has tripled on health. And obviously now within the ministry we need to categorize which goes to where. It will not come from the central government. Yeah, but most importantly, partner on this law has made a huge contribution to what we are achieving. That's what we are able to start together. So my pledge is to really anchor that our commitment to partner with any partner with intention to complement government efforts will remain unwavering. And therefore we're really looking forward to further collaboration. And if you don't have to come with cash, come with technical capacity, bring that will help surviving for the child. Yeah, so we take any resources to ensure that those indicators go down, so that by the time it's 20,000, we can able to speak out loud that we have achieved it with a partner. Thank you very much.
Every newborn counts sustainability, and therefore our commitment is to make neonatal essential drugs affordable to every single baby that requires it. We need to have
I think it's all wise doing here to thank the President of Tanzania, nation, the Republic of Tanzania, Dr. Samia Suluhu Hassan, who is very much committed in the newborn care. Within the same building where she said, I want all district hospitals to establish neonatal units in the need. And herself went through a number of neonatal units to be able to happen. So let's pick up 24th. Again, Lord mentioned about India. Thank God I happened to need some publication experience from the India. But the first neonatal units in India was established in 2003. And then 6, and later on the government started putting like 200 Tanzania billions every year. And the way I see, we are not there to 200 billion every year, but what I see in the next 2 years, this year, and at least in the next 3 years, and the government of Tanzania is also putting a lot of money, at least an average of 100 billion at least like 3 years. So we are moving. So let's join them together. As I said, we know what to do. It's just we have to do it, and we have to do it sustainably and consistently.
Thank you. Every woman, every newborn, everywhere, to survive and also thrive without disability. And together we can do that. So please, do share your learning. This should be two-way on the toolkit. Share what you're learning. Also, there's 1,000 tools in 15 languages, including everything in French. So lots of opportunities. Use that and make sure that what you learn is shared to others so we go faster together. Thank you.
Last round of applause for all our panelists.
Thank you very much for a wonderful presentation. We have learned a lot from you, and we are hoping for the best. We have prepared a special token thanks to Joseph Africa. One is the appreciation of your continuous commitment and leadership in strengthening the healthcare system across Tanzania and abroad, and another for your participation in this significant role in success of the 11th Tanzania Health Summit. The forum will deliver a great vital space for exchanging of pioneering healthcare insights. I would love to welcome Dr. Salim to hand this award to